Hi, everyone. I'm Jennifer Frazier, a scientist at the Exploratorium. Thank you for joining us for today's COVID conversation, our series where your questions guide our interviews with some of the leading scientists working on COVID-19. I'm honored today to introduce our guest, Dr. Joe DeRisi. Dr. DeRisi is a professor in the Department of Biochemistry and Biophysics at the University of California, San Francisco, and co-president of the Chan Zuckerberg Biohub. Dr. DeRisi has been a pioneer in the application of genetic tools to the understanding of infectious disease. In 2003, he was on the team that identified the virus that causes SARS, severe acute respiratory syndrome. Since that time, he's worked on many other infectious diseases, including malaria. Today, he's going to talk about the work that he is leading at the Biohub in collaboration with UCSF to address the COVID-19 pandemic. So please join me in welcoming Joe DeRisi. Hi, Joe.
Hi, thanks for having me here.
No, thank you. I know how busy you are, and I really appreciate you taking the time to talk with the Exploratorium audience. And I guess to kind of like just start things off, I'm a biologist, you're a biologist, and I wanted to just start with sort of a basic biology question. I mentioned you worked on SARS in 2003, severe acute respiratory syndrome. SARS-CoV-2 is the virus that is causing COVID-19. And as the name suggests, SARS-CoV-2 is closely related to SARS. But SARS only affected 8,000 people. And SARS-CoV-2, as of now, is affecting over 5 million or has affected over 5 million. Is there some biological explanation for this? What's the biology behind this incredible difference in the number of people affected?
Well, the actual biological determinants that have allowed this virus to spread to such a greater extent are not yet known. That is something people are working very hard on. I will say that it may be related to the degree to which this virus is able to transmit before a patient is symptomatic. And that period in which a patient is secreting viruses, they're transmitting viruses to their environment before they're overtly feeling bad is something that can contribute to spread, because if people don't know they're sick, they're going to get on that plane and take that trip or go out, and that may have been a major contributor into this virus's ability to get around the world quickly, as opposed to SARS-1, if you will,
So
which seemed to
SARS-1,
affect people very quickly.
okay, so SARS-1 didn't have this kind of symptom-free period. It was like when you had SARS, right away you had the symptoms. So that might be one of the reasons that it's affecting so many more people is asymptomatic transmission.
Well, that's one of the hypotheses that's out there. And of course, there's a lot of people working on that. We do know that there's a period of time in SARS-CoV-2 where people can have extremely high viral loads and be infectious, yet apparently have no symptoms. I mean, that's already been documented by many others, and therefore, I expect we'll have a better idea of what that time frame is. But it could be a period of several days. And if that's the case, that gives the virus a tremendous opportunity to transmit before the human that has it takes a behavioral change to mitigate its spread.
Like masks.
Like masks, like staying in bed,
Yeah.
if you're so sick you can't get out of bed, you're obviously not going to transmit it very much, as opposed if you're feeling great and you go out to a bar.
Right. Well, no, we're going to try to prevent that. But, I appreciate you answering some of the biology. But, as I mentioned in the beginning, what you're really known for is the application of these genetic techniques to understanding viruses. And you and many other scientists have been applying these techniques to SARS-CoV-2. But so before I get into some of those questions, I wanted to just take like the briefest pause because we do have a broad viewership, including my Annie Nancy. Hi, Annie Nancy. So just the briefest genetics primer, viruses have genes just like we do. And these genes are basically instructions for the things that make up a creature. And the whole set of genes is called a genome. So if we're using the word genome, it's just the whole set of genes. There's a Jennifer Frazier genome, there's a Joe DeRisi genome, squirrel genome, sea urchin genome, on and on to SARS-CoV-2 genome. So Joe, that we're done with our primer, but Joe, I think, the question for you is, you and other scientists are doing a lot of this analysis. And one of the most important questions, as you already hinted at, is how does this virus spread? Have there been any insights into how the virus spreads from some of the genomic analysis of SARS-CoV-2?
Yeah, so one of the more important things we can do when we identify a individual that's positive for the virus is we can sequence the genome from that individual. And one may ask the question, well, since the genome's already been sequenced, at least once and many, many times, in fact, in truth, it's been actually sequenced thousands of times. Um, what value does that really have? And it turns out it has tremendous value. And I'll tell you why. So this virus in particular has has the ability, obviously, to replicate itself,
So to
but it
copy
doesn't do it
itself.
perfectly.
Okay, so it can copy itself, but it's not doing it perfectly. It's
And in fact, every 2 to 3 transmission events, that is 2 to 3 people that get it in a chain of transmission, the virus makes a mistake. It has approximately 30,000 nucleotides, pieces, if you remember your biology, DNA's A, T, C's, and G's, and
right.
this is an RNA virus, so it uses, A, U, C, and G, but, it's 4 bases. And in those 30,000 bases that make up its genetic code, once every 2 to 3 transmission events, it makes a mistake. And
When
that
it's
mistake
copying.
in copying. And it's like, like a monk transcribing a book and making copies of it. Now and then there's a spelling error.
Okay.
And then when you pass that book on to the next person and they transcribe it, if you're not telling them the rules of spelling, they're going to actually copy the spelling error too.
Ah.
And that person may introduce their own spelling error somewhere else in the book. And therefore, down the line, if I get a copy of that book, I can actually trace back and almost use that as a clock if they make those transcription errors at a regular time interval, which this virus does. So the number of mutations that we see and actually their identity give us an idea of where in time this virus is, the extent of the transmission chains that got to this point. It tells us where it probably came from, because now so many people have sequenced the genome. Depending on the virus's sequence, one can say, oh yeah, this is the one that passed through Europe first, then New York, and then Wisconsin.
Well,
As
let
opposed,
me,
no, this one was introduced to San Diego first, or that nursing home in Washington.
well, let me ask you just this. This is such probably one of the best explanations I've heard of what we biologists call like a molecular clock. But just to sort of like take it back for a second. So imagine you're saying, if we looked at the words, if we use this analogy of a book, the virus's genome is a book. If we looked at, oh, there was a misspelling in the word party, and we know that anybody who has a misspelling in the word party, it must have come from that nursing home. Oh, if there was a misspelling in the word party and beach, oh, then those came. So it's basically by looking at where the misspellings were in these sort of different words, we can trace where it came from and sort of what its path was through the different populations.
That's exactly right. And just to build on your analogy there, if you have a genome from the nursing home where there was an outbreak and the word party was misspelled, and then you later found one in the same town that was party plus beach, you would conclude this virus actually was from that nursing home outbreak and made it to that person at the beach.
Okay. So you basically are just
It
tracing
defines,
the
it
misspellings.
defines a family tree.
Okay.
These transcription errors allow us to put together a family tree of these viruses to say which virus is related to which, and you can then work backwards in time where the virus has been if you've been sampling the genome all along that time.
That's why it's so important. I mean, and I think a lot of us, we were reading these things like, oh, in the Bay Area mainly came from through Asia. Oh, in New York, it came through Europe, obviously from Asia originally. So, and oh, it was in the Bay Area for a long time. A lot of those insights are coming from this kind of sequencing every patient's sample so that we can sort of get an understanding of like where they might have gotten it and how it sort of originated? Is that where a lot of these studies are coming from? Is this genetic analysis?
It's not where a lot of these studies are coming from. It's the only place they're coming from.
All
Because
right.
that's the only way to trace the lineage of a virus from a molecular standpoint. There's no magic analysis that leaves a footprint on the patient that says where the virus came from,
Right.
unless you get the genome. The genome is its own molecular clock and record. And
Wow.
so if you have let's just use another analogy. Let's just say there's an outbreak at 2 nursing homes in your county.
I
You
hope
sequence
not.
the genomes from that county, and one outcome may be that they have their own branches of the family tree. You would conclude maybe they're eighth cousins or something. You would conclude that, all right, those viruses were simultaneously introduced to these nursing homes from different locations. But what if, we're making this
Yeah.
up obviously, but what
Yeah.
if the virus was identical?
What
Then
would
the
that
then
mean?
the conclusion would be that there is likely a person, maybe a healthcare worker, that is the vector of transmission between these two facilities.
Uh, well,
And
so
so
yeah.
not only is it just an academic exercise to figure out the lineage of the virus, but it actually provides actionable epidemiology for on the ground intervention.
That's actually one of the things I was going to ask you because, obviously as a biologist, like I would love reading about like the evolution of the virus or just some of the basic science. But I think what you're highlighting is this genomic analysis of SARS-CoV-2 is actually really critical for interventions. What kind of policies do we need to put in place? What potential travel restrictions? What behavior? So this isn't just, I mean, I think a lot of us just love science for science sake. This is science that can be very readily applied to like policies that need to be put in place. And is that one of the things you guys are trying to accomplish?
That's absolutely right. As here at the Biohub with our expansion CLIA lab that we have been operating in collaboration with the UCSF Clinical Microbiology Lab, we have been processing samples for a variety of different counties across California and their departments of public health, as well as many other entities. And we are sequencing the genomes from all the positive samples that we get.
Wow.
And we are depositing those in a public repository that all the other researchers across the world are doing the same thing. It's called GSAID. You could just Google it. And there's some fantastic analysis and visualization tools for the aficionados out there. Probably the best website is called NextStrain. And you
Next
can
screen.
actually go on there and visualize the global family tree of coronavirus with respect to this outbreak. And you can look up on the search box all the ones in California, for example. And so
Whoa.
you can play, citizen scientist and go play with that data right now.
Okay, well, I'll do that as soon as we finish up. Or I just thought of my daughter's summer project. She's gonna love you. Hey, honey, guess what you're doing this summer? No, but seriously, so what are some of the things you've learned by looking at this? You or other scientists, when you look at next strain and just how the virus is evolving and moving, what have been some of the like most interesting insights from this type of data?
Well, I think this is everything's evolving and it's a shifting picture. But one of the early conclusions we can make about the Bay Area, and I can only speak to some of the things we know about the Bay Area with regard to the rest of the country, is that unlike other places around the country which were dominated by a single branch of the family tree, using the family tree analogy again, like New York,
Yeah.
um, the Bay Area uh, very clearly has had multiple independent introductions, but
Oh,
those introductions have not exploded and taken over like they did in New York. So you don't see long transmission chains emanating from any one introduction. They're all very short. So it's as if many introductions are coming into the Bay Area, maybe by travel. Who knows? That's just a hypothesis. But they're not going far. 2 or 3 people get sick, 10 people get sick, but then it stops. And
whoa.
that's good because we are using social distancing and other behavioral modifications to prevent the transmission. So it says to me, we as the Bay Area are doing our job. We're doing a good job because we're not seeing an explosion of any one of these introductions. But at the same time, we are not defending ourselves against introductions because they keep coming in. And that's one of the things that this genomic epidemiology can do is it can help you identify in a particular region or county or town or whatever, um, or a college campus. Once you know what the strains were of the virus that were in your area, where they were in the family tree, if you see one that's like from a totally different branch of the tree, you can conclude very rapidly that that was a new introduction.
Oh,
And
whoa.
so then you can ask yourself, well, where do people come in, and where is that occurring? Is that occurring at our airport? Did they come in on a train? Where's the flow? And if enough genomes have been sequenced in the state, obviously you would track back where that lineage came from. And who knows, maybe it's a linkage to the state nearby. And you would then know that there's travel between those two places. And again, you would be able to use traceback, your ability to trace back where things occurred, and that would allow you to have real interventions.
So it sounds
Yeah.
like, I mean, I know you've been called like a, virus detective, but this in some ways does sound like it's in some ways detective work, like figuring out like, oh, where might this outbreak have come from? How might it be spreading through the population? But again, it's not, even though many of us just love science for science sake, it's also science that can then very quickly be used to like help us figure out how to prevent the spread or tell us what's working. Like even I didn't realize when you just said that we have had many introductions into the Bay Area, but then they're not going far. I think that just highlights again that this social distancing really has had a big impact, and it might help explain why we've had a lower, death rate in our area than other regions. So that's really interesting.
Yes, that's right. And I think that this is a very powerful tool. And we here at the Biohub are working to put together data analytics and visualizations together with our partners in the other parts of the country and abroad that would ultimately put tools in the hands of your local epidemiologist to use this genomic sequencing as a way to turn it into actionable intervention. And
Great.
that is the goal here. It's not to publish the next scientific paper, get a manuscript, and all that. Well, that's important for communicating results. The more important aspect is what can we do that's immediately actionable on the ground right now to stop this virus?
Well, it's, I mean, I'm so excited to hear that. Not that I don't love, reading nature papers or other peer reviewed publications, but it does sound like, I mean, what our world needs right now is to stop the virus and get our lives back, save lives. So I really appreciate everything you and other scientists are doing, and building tools like that that can be used by people around the world is amazing. And I guess that, I wanted to ask you one or two other kind of genetics questions before I did ask more about the testing you're doing. I mean, I know one effort you have been really involved with in collaboration with UCSF are these population studies. We in the region have been following closely, right? You've been looking at the densely populated Mission District in San Francisco. You've been looking at a more remote beach town in Marin County called Bolinas. I mean, I know that maybe you're still doing the sequencing. Why would you study populations like this, right? I understand now you've explained, oh, when there's a patient, someone's sick, we sequence it. These were just whole populations. Maybe people weren't sick, and you looked at both these populations. Why do a population study like that? And what have you learned or could you learn?
Mm-hmm. It's a great question. So just to step back a moment to understand, so your viewers understand like what we're actually up to here. We partnered with UCSF here at the Biohub to create an expansion clinical testing lab. These are often called CLIA labs, and what that means is they're different than the research labs. A research lab, you can't actually use your equipment and reagents to test for the virus and report that back to a patient. That's actually illegal.
Oh,
It is not allowed under state or federal law, and that is to protect patients from potentially bogus results that would harm their health.
good.
Um, a clinical lab operates under much different set of standards. And so what we did here at the Biohub is we took the initiative and converted a large fraction of our research capacity into clinical laboratory testing. And we were armed with a huge number of volunteer graduate students and postdocs from the UCSF community. So we had both the labor, the workforce, the automation, the equipment, the space, and the know-how. And together with our clinical microbiology lab partners and our medical director at UCSF, we were able then in only 8 days to go from an empty lab to a go live clinical test for patients.
Oh my God, that's
Um, and
amazing.
I'm just looking at our dashboard, and by the end of today, we will have returned over 20,000 clinical results to patients.
In how short a time?
Well, now we've been operating for about 2 months,
Oh my
but
gosh.
we're only accelerating and getting
Wow.
faster. And so this is, I think, a really important aspect because again, it isn't about publishing that next science paper. It is really about what can we do now to defend against this virus. And it is important that people have actionable testing results. And what we saw, unfortunately, was the big labs and major corporations were not at the scene early. They were not fast, and they cost lots of money. And so we felt it was important, and our organization feels it's important to get that testing to a wide number of people who otherwise might not get tested at all. And so we work very closely with our local and county level departments of public health throughout the Bay Area and beyond. And many of those departments of public health would not have the finances to be able to purchase commercial tests and so on. So
Wow.
we're helping to enable them to provide testing for, frankly, the populations that are often most in need and most vulnerable, including unsheltered individuals, long-term care facilities, and patients that go to safety net clinics where nobody has insurance and so on.
Wow.
So
That's
this is an important service that I think is valuable to offer at the same time doing all this sort of, high-end genomic sequencing and science. The basic returning a test to an individual is in fact the core of what we're doing now.
that. Well,
And we
I'm
do
glad
that
you
very fast
clarified because
and
I
very
mean,
efficient.
and you're transitioning into something that, I was going to ask you a few more genetics questions, but I do
Well, I
think
was going to get on to the studies. We'd love to tell you about that,
oh, no,
actually
yeah,
answer your
please
question.
do. I mean, but thank you for doing all this testing because I think you're highlighting, let's talk about Bolinas and the Mission District and populations. But I just wanted to say how much I'm sure our whole community appreciates that you're providing testing for those who really need it. And I think that's maybe what you're going to get into because I think we know that there's probably a disparity in incomes in the different communities that you're looking at. So you want to tell us a little bit more about this Bay Area study?
Yes, I do. And so just to round off where I was going with this, so and not only have we built this clinical lab testing capacity, but we've shared all our protocols and we've informed others on how to do it too. And so, for example, UC Berkeley has spun up a smaller version of this, and we taught their people how to do it and showed them the protocols. And so we've been spreading the knowledge and empowering others to get similar things going. And so that's been another function. But one of the things that we've really been engaging in, besides working with our departments of public health, is engaging in community-based studies. And so Diane Havler is one of our highly respected and distinguished clinical
Yes.
um, scientists here at UCSF. She's famous for a lot of HIV work and so
Yeah.
on. And she booted up a study in the Mission District here at San Francisco to in a 4x4 block area to recruit as many people as she could door to door.
Wow.
And she had several hundred volunteers that helped with this. And we here at the Biohub did all the testing on that. So in a 3-day period, we tested 4,160 people. And
Amazing.
what was really, really interesting about this, and all the results are not yet in, but this is all public knowledge already, is that there was some real disparities in who was infected and who wasn't. And I think the community had already some understanding that the Hispanic, Latino, and Latinx community was unusually hard hit by COVID-19.
Yeah.
And this study fully confirmed that 95% of the infections in this district were in that community.
Oh my goodness.
And were largely in households that made less than $50,000 median income and had large numbers of people living in the household. So that confirms a lot of what we suspected is that this virus is not, in fact, equally distributed in our communities.
No.
It is very unevenly distributed. And probably the most significant take-home result from this was that 90% of the people who were positive for the virus stated that they were not able to shelter at home. They had to work outside the house. And so if you were able to shelter at home, your chances of being infected are much, much, much lower. And those breadwinners who have to work outside the house are at much higher risk. And that was extremely evident in this study.
Well, and I think what's really important is you need the science to confirm this, right? We can see some of that. And I understand some of the work was also working with the communities to give them knowledge of transmission. I mean, and this health disparities issue, I'm going to be talking with Dr. Kirsten Bibbins Domingo soon too, because this obviously is something that's really distressing. But it's important to have the evidence that you guys are providing that this is actually happening so that we can start to think of how we might address this.
That's right. And we are working with Kristen Bivens Domingo and Diane Havlier on round two follow-up studies on other communities here in San Francisco. So stay tuned for that.
Yeah.
It's important to note that this wasn't a research study. These were clinical tests returned to every patient so that they're actionable and that Diane and her team and the Department of Public Health can intervene and assist those families so that we stop the transmission of the virus and make our whole communities more healthy.
Good. No, I'm so glad that you're doing that. And I think I mean, it sounds like already the insights from that study are helping us figure out again, kind of like we were talking about, well, where do things come from? And then what's the policy? You're already having actionable interventions where you could help a family if maybe they have asymptomatic transmission. Hey, you tested positive, so you need to go into isolation. It provides them an opportunity to like make decisions based on some of the results that you're bringing in. So that also emphasizes, I think, for our, most of the general audience here, I think what the testing issue, right? I mean, clearly you brought up you're running this testing facility. You've pointed out, and I think we all realize how critical testing is. It keeps being brought up as an indicator of whether things can open up or not. I mean, it's been week by week, it changes so quickly, but where are we right now with testing? I mean, do we have enough testing? Are we close to some CRISPR based pregnancy test for COVID-19? I mean, are we any closer to getting the testing that we need, quick testing?
So I think that there is actually a lot of unused testing capacity in the state. Question is at what cost and who charges what and which ones for free and which ones aren't. And so who bears the brunt of the bill is part of the question. I know that many companies have brought up a lot of testing capacity, but those aren't for free. And
Right.
who can pay $100 a test versus who can't? And so that adds another layer of complexity. And then second of all, what are the information systems that the states are using to balance testing load over capacity, and how are we going to deal with the cost of those things? Those are all issues that are, I would say, in the way of getting enough testing to everybody. But I do also think that our studies have highlighted that maybe it isn't a the smart way to go just to test everybody, because first of all,
Right.
that's not practical. It's going to
No.
cost too much money.
Yeah.
And knowing that the virus isn't evenly distributed. You mentioned the town of Bolinas. We also participated in that study, which was about 1,200 or so people, and
Right.
there was not a single positive person in the whole town. And
Whoa.
so, that only goes to show you that this virus is not evenly distributed in our communities. And so we should be testing smarter, not just testing
Right.
more.
So it's about testing smarter, and then maybe for, I guess for just the average person out there, not average person, but maybe if you're in the high risk areas, right, like nursing homes, frontline workers, essential workers, healthcare providers, maybe we need to make sure that we're absolutely prioritizing free or low cost, readily accessible testing. And then for people that may be able to like have the privilege of removing themselves from some of those situations, it's less urgent. So I like your saying sort of like smarter testing. Is that sort of the strategy that people are thinking right now?
I hope.
You're like, that's what I'm doing. Well, no, I mean, I guess, okay, I want to ask you one last, we're going to get to like, I know you have a lot too. I only had a few I have one sort of wacky question that I think we've gotten a lot. And then I'm going to ask you some more practical questions.
Go for
Wacky
it.
question. I know you might be able to answer this if there's an answer. A lot of people have been like, I know genetic analysis can be used to like study how things have evolved, right? You talked about these clocks and being able to trace things. this isn't as applicable to like what we're going to do now to treat the disease, but there's a lot of curiosity about where the virus may have come from, and especially, was it bats? Obviously, it's not going to change a lot about what we're going to do today, but I mean, do you, as someone who's found viruses in pythons and leopard sharks, I mean, you've looked in all kinds of organisms. What do you think there's any understanding of where SARS-CoV-2 came from at this point?
Absolutely. It definitely came from a bat. There's no
All
question.
right,
I
there
mean,
you
that's
go.
not
Okay,
that's not up for debate.
it's
That's
more how did it get to humans?
Yeah, how did it get for humans? Was there, whether there was an intermediate between the bat and the human is rather academic.
Yeah.
Um, there is no question from an evolutionary standpoint that this is a bat coronavirus, or was in its recent history. And we also know the bounds on its introduction. Remember, I said the transcription errors in the virus form a clock.
Right.
Because we know so much about this virus now, and so many have been sequenced, the confidence bounds on that clock are extremely tight. And so we really know with actually fairly great certainty that, the last week of November 2019 is when it jumped into the very first human.
Whoa, that's
And
specific.
therefore, I often get approached by people, saying, God, I really felt super crappy in October. I know I had SARS. And my only reply is, yeah, no, you didn't.
So it's before the end of November. There's
Well,
no way.
yeah, and even after the end of November, throughout December, it took time to go through many
Right.
people in Wuhan.
Right.
There's no way, unless you worked in a seafood market in Wuhan in December, that you encountered this thing.
Okay. Well, so that clears up a lot of people, and then we won't even get into antibodies and things. But that, thank you,
I'm
because I
happy
think
to
I
go
still,
there too.
yeah, I get a lot of questions still about like pangolins and bats, and so thank you. I
You
figured I'd
want to
just
hit up
ask
the
you.
antibody question quick while we have time?
Pardon?
Do you want to talk about antibodies quick while we have time? Because I get that question all the time as well.
Sure. Yeah. I mean, if you can have the time to talk about antibodies, like that is another thing, that antibody testing and whether people have antibodies, that's another thing we're seeing a ton of questions about. So please, like, if you have a perspective on that, I know I figured since you hadn't been directly working on antibodies, I didn't know if I should ask, but if you're willing to share your understanding, that'd be great.
Yeah, we actually do work on serology some. We have a preprint in bioarchive on one of our
Oh,
pieces there.
great.
But it's not, you're right, it's not our main focus, and we don't do serological testing in our CLIA lab here. There is serological testing at the clinical lab at UCSF proper. Um, but maybe you could start with like, what do you think the main questions are?
I mean, I think the main question that I see from our audiences is really about whether these antibody tests, you can tell anything from the antibody tests, and whether antibody testing is useful. So, I mean, I
Okay.
know those are actually big questions.
Yeah. Yeah, absolutely. So let's first start from an epidemiological sense. Like, if you wanted to understand the prevalence of a disease in a given area, the antibody test is quite nice, assuming that it's accurate. And that we've learned, of course, there are many tests that are not accurate right now.
Yeah.
I think that the FDA announced today there's like 25 manufacturers of these tests that are now forbidden to sell them because they're so bad.
Oh my
Um,
God.
but that aside, let's imagine they were very good, and some of them seem to be pretty good.
Okay.
That test can give you good epidemiological information about prevalence of a disease in an area, because you don't have to catch the disease in the person at exactly the right moment. It can give you sort of a retrospective history of who's been exposed to the virus.
Okay.
So from an epidemiology standpoint, it gives you an idea about how many people are getting it. It's called seroprevalence. And if you measured that over time, you could measure, well, whether that number is staying the same or if it's going up. And that would be a complementary measure to what you would get by measuring the incidence of the virus, actually measuring for the presence of the virus itself in an individual by PCR, which is how most of the tests work.
Okay.
Now, for your individual, for your regular person on the street who, let's say they felt bad if they felt bad in October, well, I guarantee it's a pointless exercise. But if they felt bad in April,
Great.
maybe
Okay.
in April, and they said, "Gosh, I felt bad. I would really like to know if that was SARS." Okay, I mean, that's cool. It's a curiosity. You might get some balloons and a box of chocolates with it, but I'm not really sure you don't do anything with that information because
Right,
number one, the serology doesn't tell you that you're protected.
right.
So it doesn't mean that just because you have antibodies that you somehow have a magical force field around you and you can just walk without a mask and you're going to have no problems. That is definitely not what it does, and it should not be used to give people a false sense of security.
Okay.
Um, that's probably the most important thing. So on an individual level, it does not seem to make a lot of sense for everybody to run out and figure out if they have antibodies to it, unless they really, really want to pay for it out of pocket because it's not clinically necessary.
That's the thing I think that people, and especially in the beginning, when we just hear testing, I think the important distinction is there's this more PCR, there's testing for like whether someone actually has the virus right now, like looking for the virus versus looking for whether there were antibodies. So I think that distinction, making that clear. And then, like you just said, even if you did have the antibodies, right now it's meaningless basically, because even if, let's say I went out and I spent money, I got tested, I had antibodies, we don't know if those antibodies are protective. So it's almost like, you're right. I like that you're sort of cautioning. I actually had, yeah, I shouldn't get into anyone else's, but I've had people tell me, oh yeah, I'm getting antibody testing so that I can like go travel this summer. And I'm like, no, what, hold up. So I think that's an important thing to emphasize to the
Yeah,
public.
you can't use that to say you can go travel. The best you could do is put a little gold star on your shirt and make yourself feel better, but it's not really going to be good for anything.
Well, that I think, thank you for doing that, because that we get a lot of questions about antibody testing. And I guess I know our time is starting to wrap up in this question, even just talking about travel. I think one thing we've found is that a lot of our audience is very interested in, like, understandably practical questions, right? There's a lot of science, but then how does the science translate into things we should be doing? Because it's really hard to keep up. And you are Joe DeRisi, the amazing scientist, but you are also Joe DeRisi, the human being who has to go buy groceries, who may have a house that has like a broken pipe. I know because I studied at UCSF when you were there. I know that you have children who may now be much larger than when I was there. Do you mind answering a few questions? Given I know you're not a
Sure.
public health expert or a doctor, but like what does Joe do? Do you mind answering a few of those?
Yeah, go for it. Let's
All right.
try.
So travel, summer's coming. This is coming up a lot in the questions we're getting from our audience. Like Joe DeRisi, infectious disease expert, what kind of travel plans are you making for you or your family this summer?
Well, as one of my favorite characters on Saturday Night Live used to play George Bush, used to say, "It's like not gonna do it."
Okay. So not even, you're not going any, are you going to even like go on day trips or like a weekend somewhere in a well ventilated cabin, just going to stick around?
All canceled everything.
Okay. Wow. Well, note to self, my kids aren't going to like that answer, but okay. And then what about similarly, again, summer's coming. A lot of our audience have children. You have children. I don't know. I think they're probably beyond camps now, but like, do you think kids can safely go to camps right now? I know camps are working hard on it, but like, what kind of would you be thinking of sending your kids to camp or not?
That's a really tough question. I don't. So all the camps that my kids would have gone to are all canceled. So
Right.
the question is moot. But the to whether if you were hypothetically opening a camp in late summer, you would probably want to have some sort of mechanism where you could isolate the individuals and test everybody before they came to camp, one day before they came or something. I just don't know how practical that could be.
Yeah.
And um, you know, camps, especially a lot of these summer camps, they're all about congregate living. That's all they are. You have 14 kids in a tiny little cabin,
Yeah.
and I can't imagine a better place to transmit virus. So
That's one. Well, that.
I would be concerned. I hope we can get to a place where the prevalence and the incidence of the virus is so low that we feel confident in doing that, but we really have no crystal ball. And I'm worried right now that even though we've done such a great job in the Bay Area, a lot of counties and states and stuff are beginning to loosen those regulations awfully fast. And what we've learned from history, especially like the 1918 flu and stuff, is that there will likely be a resurgence of the virus.
Yes.
And if that happens, we could see a lot more people get sick, and these kinds of activities could contribute to it. So, in general, I'm a very, very cautious person when it comes to this.
To
I unfortunately think that those activities are unwise.
well, this is, we actually, I don't know if you know George Rutherford. We had him last week talk about
Yeah, I know him
1918.
well.
Yeah, no, and I mean, I think something he said, I think it's so good to have you guys in this moment, even if people watch these later. Right now, the Bay Area's done a great job keeping things under control, and people have been home for 2 months. They're going kind of bonkers. Summer's coming, and even if you had online school, there was online school, and now it's like, what are we going to be doing? But I think it's not the time to let up. And I think that message is so important to get across, because I think right now, oh, no one's really sick here. Oh, I'm in Marin. No one in Bolinas was sick. And it's not time to like let off, because as you said, all it takes, the Bay Area's had multiple introductions. All it takes is one person coming in here, and if we're not wearing our masks and we're not careful, all of the hard work sort of, again, like you say, you're cautious. You don't want, I don't, none of us want to be negative, but I think we want to make sure that until there are really great treatments or a vaccine, we don't let off. So it's good to hear your perspective, that you, someone who knows a tremendous amount about this virus, is remaining cautious. And some people might have to send their kids to childcare, given that they may be essential workers, but really keeping your family close and being careful. That sounds like that's what Joe DeRisi, the human being, is doing.
That's right.
All right. Well, Joe, given the number of things, I mean, trust me, I have so many questions about like Hulk-like viruses and other. Maybe we can have you back again sometime, but I know you have a lot to do, and the whole exploratorium community. I mean, I know that you go to the exploratorium, and we love having you and having you involved. And our audience really appreciates you sharing your expertise during this really hard time, not only to help us understand all the science, but also just share your perspective on like what's important, what we're learning, and even what we need to do to like help plan our lives. So thank you for taking the time.
Yeah, I'm happy to do it. I love the Exploratorium. It's one of my favorite places in San Francisco ever since I was a little kid.
Since you were a
And,
kid,
I hope one day, we can have a world where going back to the tactile dome is
yes,
okay.
you will be. We're all going to be back in the tactile dome. It's going to happen. But as I keep, this, and I keep telling my kids, I'm like, just be patient. We're all going to be back there, and we'll have a big party. Me, you, George Rutherford, and all the COVID conversations guests are going to be in the tactile dome without fear one of these days. All
Well,
right.
that
Thank
would
you
be a
so
hoot.
much, Joe. Have a great rest of your week. And thank you again for taking the time.
Bye now.
All right. Bye.